Hello everyone, my name is Desiree Jones and I'll be doing my case scenario over hypercalcemia. Some learning objectives would be being able to explain and or define hypercalcemia, being able to distinguish normal and or abnormal physiology that help diagnose hypercalcemia, and being able to correlate the disruption to normal physiology with the most common clinical presentation or the most common symptom. A brief overview. Let's start by breaking down hypercalcemia. Hyper means high, calc means calcium, and emia means in the blood. Most commonly, this results from an overgrown parathyroid, which is our green spots here on our thyroid, or from malignancies like malignant tumors. High calcium leads to neurons being less excitable, and this can lead to slow reflexes, slow muscle contractions, or an affected central nervous system. Let's take a look at normal physiology. So 99% of calcium is in the bone, 0.99% is in the ECF or extracellular fluid, which includes blood and interstitium, and 0.1% is in our ICF or intracellular fluid. From here on out, I'll be using ECF and ICF respectively for extracellular fluid and intracellular fluid. To keep levels of calcium balanced between the ECF and ICF, there are ways to get calcium in and out. Those ways would be ligand and voltage gates, which control what comes into the cell, and calcium pumps and sodium-calcium exchangers, which control what goes out of the cell. ECF has two ways to let molecules in and out, the first being diffusible, where we have free ionized and complex calcium coming in and out. These are small enough to be diffused. Or non-diffusible. These are the larger molecules that can't come in and out. An example would be albumin, which is a protein. This is a beautiful picture of the normal physiology occurring. So ECF calcium level changes are detected by calcium sensing receptors on the parathyroid cell. So here's our receptor that's going to detect any levels or changes in the levels of calcium. This affects the amount of parathyroid hormone that gets released by the parathyroid gland. So when that receptor senses a change, our parathyroid hormone is going to be released. The parathyroid hormone gets bone to release calcium, kidneys to reabsorb calcium or synthesize calcitrol, which is an active form of vitamin D, and vitamin D to cause the GI tract to increase calcium absorption. Overall, these effects are to keep calcium levels between 8.5 and 10 milligrams per deciliter in the blood, which is our normal levels. All these processes cannot occur if we do not have electrically active neurons. So these synapses that occur between the hormone and the bones releasing the calcium and the kidneys doing their job in the GI tract, these can occur if those synapses don't occur from the electrically active neurons. So disruption to that normal physiology, our true hypercalcemia, most commonly occurs due to osteoclastic resorption. So here's our blood. Sorry, this picture is terrible. Here's our bone, and here's our osteoclast. Osteoclasts are bone-eating cells, and they frantically break down bone and release calcium into the blood, But there are times where osteoclasts release way too much calcium, which leads to hypercalcemia. And some ways that can occur is from that overgrown parathyroid, which increases more parathyroid hormone to be released, or malignant tumors, which release PTHrP, which is a parathyroid hormone related protein, and that protein mimics our parathyroid hormone's job. Remember, our parathyroid hormone stimulates osteoclasts and osteoblasts, which osteoblasts are bone building cells. Some tumors cause the osteoblasts to die off, which that can lead to lytic bone lesions. That's typically seen in malignancies, and it's because we have more osteoclasts than osteoblasts. There are other ways that we can have too much calcium levels in the blood, and that's from excess vitamin D, which typically comes from our diet or taking too much of the supplement, and that's going to increase absorption of calcium through the gut. Another way is medications such as thiazide diuretics, which increase reabsorption in distal tubules of the kidney, which is going to lead to an increase of urine output, which will typically show in a patient through dehydration. Lastly, we're going to talk about our patient's symptoms. So how does this correlate to the normal and abnormal physiology? So high levels of ionized calcium, which is our hypercalcemia, affects many processes. But in particular, we're going to look at electrically active neurons. So our normal physiology is normally when we see calcium stabilizing the resting state of sodium channels, which prevents calcium from spontaneously opening and letting sodium into the cell. A word to summarize all that is depolarization. When we have abnormal physiology, we have high levels of calcium, which lead to the neuron having sodium channels less likely to open, making it harder to depolarize. And this is going to lead to a less excitable neuron. Now, when we have a less excitable neuron, we don't have our synapses occurring in our normal physiology. Patients who have a mild hypercalcemia may not even have symptoms, but if you have a more severe case of hypercalcemia, you're going to have severe symptoms. Some of those symptoms can be slower and or absent reflexes, which is our classic symptom. That's our telltale sign that we may be leading to hypercalcemia. And that's because we're not having those synapses between the neurons, and you're not going to have those normal reflexes. Next would be slow muscle contractions. Muscle contractions, which will lead to constipation and muscle weakness. And this is usually because of the sluggish firing of neurons. Lastly, it can affect the central nervous system, and some symptoms would be confusion, hallucination, and stupor. Stupor is when you're in a daze or nearly unconscious. Some of us have seen the state of being in stupor when you see a drunk person or being drunk. So overall, what we're looking at is these electrically active neurons are not synapsing well, and they're not allowing these processes to occur. So we can't have our bone release calcium or our kidneys release or synthesize calcitrol or reabsorb the calcium. And we can't have that vitamin D being made so that the gut can reabsorb. So all of these things can't happen because we're not having those excited neurons. These are my references. And if you have any questions, please feel free to contact me.